Hello guys, and welcome to the lecture on our peripheral nerve problems, and this is chapter 60 in your book. It starts on page 1439 and then it goes through till the end there. So we're going to be talking about a couple cranial nerve abnormalities as well as a few polyneuropathies. So let's go. First off, I want to talk about cranial nerve 5. And so this is our trigeminal nerve. And so the trigeminal neuralgia is a problem with usually sensory issues. It deals with a lot of severe recurrent episodes of pain where the trigeminal nerve innervates, and that is all over the face, basically. So the fifth cranial nerve, actually, it branches into 3 different areas by like the forehead, the cheekbones, the mandibular area, and then also down the chin, here where you chew. So the trigeminal nerve has 2 main functions. It helps us feel sensation in our face, and it also has motor functions for us to chew and to clench down. So patients with trigeminal neuralgia, they're going to have intense pain, and they also might have some kind of unilateral grimacing or blinking and tearing of the eye that is affected by that inflammation of the trigeminal nerve. Here's a picture of that branching of the trigeminal nerve. So you can see kind of up by the forehead, they call that ophthalmic division, and then more cheekbone is maxillary, and then chin is mandibular division. So usually what is affected is the maxillary and mandibular portion when we have trigeminal neuralgia, but it can occur anywhere where there is inflammation of that nerve. So to assess for trigeminal cranial nerve 5, we need a cotton ball and a sharp object like a pin or a safety pin or something, because it is a sensory and a motor nerve. So for sensory, we want to use our cotton ball and see, does the patient feel us touching? So we'll have them close their eyes and say, am I touching you? Do you feel this? Something like that. In all 3 of those nerve areas bilaterally. It's always test bilaterally. And then after we have attained our answer there, we're going to take our soft and sharp object and we're going to see if they can tell the difference. My touch, is it soft or is it sharp? Or touch them with the cotton ball and say, does this feel the same or does this feel different? And something to get them to identify that you are touching them with 2 very different objects, a cotton ball and a pin. Just be careful with your sharp object. We don't want to draw blood. And so that's for the sensory assessment of cranial nerve 5. And then going with the motor assessment, have them move their mandible, up and down, so jaw up and down, and then side to side. So it should move easily. They shouldn't have any pain with moving it, and that will give us our motor assessment of the trigeminal nerve. So collaborative care for trigeminal neuralgia, we want to start by taking a history and physical, and that includes, a full neurological exam. We can also do a CT scan and an MRI to rule out other causes of pain, such as infection of the sinuses, possible cancer or tumor lesions that are causing changes with the nerve, and even multiple sclerosis. So as interprofessional care, what we can do for these patients is we can do different drugs. So there are lots of different anti-seizure medications, and these work by reducing the pain, and they help kind of stabilize that nerve pathway and block the abnormal nerve firing, which is causing that pain in the mandibular maxillary area. And so some of the drugs that we see common is carbamazepine and oxcarbazepine. So these are seizure medications, and the brand names are Tegatrol and Trileptal. And so we, again, see those pretty frequently. Lamictal, too, I see pretty often. that we can use to help with that pain. Gabapentin is another nerve pain medication that we can use, as well as tricyclic antidepressants. They help with pain relief as well by working on those nerve pathways. So some of the TCAs that we see are amitriptyline. We can see that being taken for trigeminal pain. If that conservative approach doesn't work or the drugs don't work, we also have some nerve blocker surgery that we could do for patients with trigeminal neuralgia. So for nursing management for the cranial nerve 5 or the trigeminal neuralgia, things that we want to think about are how can we reduce these triggering factors with the patient, and some of those triggering factors can be cold. So try to keep the room pretty even keel, try to reduce drafts in the room, because sometimes those temperature changes can cause a flare-up and can cause some pain with the patient there. We really want to make sure that we're seeing, how often it's occurring, so we can get on the right regimen. We can offer different treatment plans as well, such as acupuncture or yoga seems to help. I don't know how with the yoga, but it has been shown to help with cranial nerve 5. And then we want to assess how the degree of pain has affected the patient's lifestyle, how it is affecting any drug use, their mental health, and causing any up to suicidal tendencies. So nutritional status, that is definitely important with our trigeminal neuralgia, because again, it's not only a sensory causing lots and lots of pain, but it also can be a motor dysfunction, or the pain can be so severe that the patient doesn't want to eat and chew, because that mastication is going to hurt. So let's assess their ability to eat. Does the pain limit their food and drink intake? Is it hindering their nutrition? So we can tell them to take in foods that are high in protein and calories, but are also soft. And what comes to mind for me are these like Ensure shakes. So getting a form of nutritional supplementation that is going to be as good, as nutritionally sound as we can, but yet it'll make it easy to eat for the patient so that they don't lose that good nutrition for all the body mechanisms. The other cranial nerve disorder I want to talk about is Bell's palsy. And Bell's palsy is a facial nerve disorder of cranial nerve 7, or our facial nerve. And so Bell's palsy, some people can call it peripheral facial paralysis, or the medical term, an acute benign polyneuritis, so inflammation of several nerves, that is benign because as we go through talking about Bell's palsy, we always want to rule out stroke. So Bell's palsy is a great thing to note anytime they're especially getting treated or seeking medical care. You want to know if they've had a history or have Bell's palsy, because every single time I see a patient, even if I know they have Bell's palsy, I go, stroke in my head. And I know my game face hasn't been on all the time, because they will like be like, don't worry, I have Bell's palsy, and they just see the relief on my face. But anyways, Bell's palsy is the inflammation of that cranial nerve 7 unilaterally, so on one side of the face, and again, not stroke. This can be acute, or it can be a chronic condition that the patient will live with. So how do we assess cranial nerve 7? Well, since it's a facial nerve and it controls the motor functionality of our face, we want to check for symmetry in the face, or weakness on one side or the other. And this is best noted during normal conversation, just kind of going with the patient. They usually don't have any slurring or any issues with like eating, chewing, swallowing. Their tongue is fine, talking is fine, but they have this drooping, on one side of the face. And look at the picture, you can see where one side is definitely drooping and it's not as animated as the other. So with that, regarding cranial nerve 7, so I'm specifically talking about cranial nerve 7, not Bell's palsy right now, but in a stroke, so because we always want to rule out that it's not a stroke if we have a new diagnosis of Bell's palsy, we can have weakness limited to just the lower half of the face, where Bell's palsy is going to be upper and lower of the face. So sometimes the only indication is going to be this flattened nasolabial fold. So right under the tip of the nose there, that little indent there, that might be the only thing that we see in stroke. And so that we would see by having them take a big smile, show us your teeth, and then we're looking for the flattening above the lip, in between the lip and the tip of the nose. Okay, going back to Bell's palsy. So Bell's palsy is often associated with a herpes outbreak, which is, it attacks the nerves. Herpes does. We think of the shingles vaccine and other things that that we get now to reduce the risk of having these other diseases. But the herpes virus is going to cause inflammation, and it can lead to this nerve compression, which then shows as our facial paralysis because of the compression of the facial nerve there. There are some other viruses that are associated with it, but like Epstein-Barr, influenza, but usually it is related to a herpes infection. So it shows off as a rapid onset of facial weakness that can occur within a few hours, and then it might progress in the next 2 days, that facial weakness. They might also have some pain behind the ear, might have some other manifestations along with it, such as ringing in the ear, headache, and flaccidity, on that affected side. So one thing we can do as well as assessing for Bell's palsy, another assessment piece that we can do with Bell's palsy is have them look up and then attempt to close their eyes. And if the one eye can't close, that is called Bell's phenomenon, and it is the inability of the eyeball to close when, of the lid to close when the eyeball is looking up. Yes. Complications related to Bell's palsy include our psychological withdrawal because of the changes in appearance in their face. They can have malnutrition because of the weakness on one side, and the making it harder to eat. May become dehydrated because they're not intaking those fluids and liquids. Corneal abrasions are common because the eyelid is very droopy. There is a increased space in between, like the eyebrow and the lid of the eye, facial spasm and contractures. So for interprofessional management and things that we can do for Bell's palsy, the most important thing to do when we notice the clinical manifestations or the signs and symptoms of Bell's palsy is to always rule out stroke first, because it does mimic stroke of that, hemiparalysis, weakness of the facial nerve, possible, slurring in the first couple days where Bell's manifests. So we always want to exclude stroke first before diagnosing Bell's palsy. And then our treatment is going to be symptomatic relief. And that can include treating the viral infection so that we don't have that pain, behind the ear, or that ringing in the ear. If we can start corticosteroids, so an anti-inflammatory, right away when we see the symptoms and we rule out stroke, it actually helps with long-term disability with the facial nerve. So we will start it right away. It's best to start before the first 2 days because that's when the manifestations get worse. They, are abrupt in onset, but yet they get worse in those first 2 days. So if we can start a high-dose anti-inflammatory, we can help with a long-term prognosis there. And then eventually we'll taper them off, those corticosteroids, kind of like we would do with a regular prednisone taper. So nursing management for those symptom relief would be protecting again from those cold drafts, because that can increase pain with the inflammation of the facial nerve there. We want to protect the eye, since we talked about corneal abrasions are common through that eye. So making sure we have some sort of like eye drop, maybe Refresh preservative-free eye drop to help with those corneal abrasions, and giving pain medication as needed for any nerve pain that they are experiencing. So then we're going to move on to the polyneuropathies, and the first one we're going to talk about is Guillain-Barre Syndrome. This is an acute, so rapid onset and rapidly progressing, potentially fatal form of the polyneuritis. And the characteristic manifestations of Guillain-Barre are an ascending, so going up, symmetrical paralysis that's going to affect both cranial and peripheral nerves. It affects the nerves by having a demyelinating type pathway. So we will see progressive loss of muscle function due to the inflammation on those nerves. And so the reflexes in those affected nerves are going to be weak or absent, and it can lead up to respiratory arrest because the respiratory muscles might also be affected. And the scary thing about Guillain-Barre is that it might lead to needing mechanical ventilation for weeks, because the maximal weakness is usually reached within 4 weeks of onset of symptoms of this Guillain-Barre. But it is rapid and it is acute, and Guillain-Barre is thought to be autoimmune brought and exacerbated by a viral or bacterial infection. So part of our diagnostics of Guillain-Barre, besides looking at our clinical manifestations, are asking if they've had a recent infection. I know I had a friend at work that always gets out of her flu vaccine because when she was a young girl, like 6 years old, she had Guillain-Barre following influenza. And I can't imagine, you know, how scary that was for her parents and for her. But she is definitely, you know, excluded from the mandatory influenza vaccine at our place of work. Sorry about that, I hit the wrong button here. So Guillain-Barre, let's talk about assessment here and what we should look at. So again, taking an H&P and looking for a recent bacterial or viral illness. Pain usually starts as paresthesias in the distal limb. So as you can see on the picture there, there's kind of redness in the hands and feet. So distal limbs there. So, and it's manifesting as pain right away. And then it progresses to the absent or weak reflexes. So testing those deep tendon reflexes when we are definitely going to see weakness. And this is a symmetrical weakness, whereas usually stroke or other like nerve disorders, it's usually asymmetrical. This is a symmetrical weakness of ascending nature, you know, going up to the core. So then we want to assess our respiratory system frequently, as this disease, again, it's progressive. It's going to happen quickly, and our patients might end up ventilated. So what are some of those respiratory assessments that we want to do? Well, we want to listen to their lung sounds, right? Are they clear bilaterally, or are they having respiratory compromise and we're hearing crackles? You know, are they not ventilating like they should? They should have normal vital capacity, so they should be able to take in a deep breath and hold it and maintain that deep breath. We want to check pulse oximetry. Our oximetry should be greater than 92%. Check our arterial blood gases, right? So PaO2 greater than 80, PaCO2 35 to 45. So we want, and a normal pH, right? 735 to 745. We want all of that when we're looking at our respiratory system. And lastly, or most importantly, looking at his or her breathing pattern. Is it spontaneous? Are we non-labored? Is there no use of accessory muscles? Those are all good things, you know, for our respiratory assessment. So again, clinical manifestations of our Guillain-Barre, it begins in our lower extremities symmetrically, right? And over days to weeks, it's going to gradually ascend or go up, and we're going to have decreased, weakened, and even absent deep tendon reflexes, you know, in our legs, in our arms. That can lead to our hypotonic state of our muscles. And then a patient with Guillain-Barre, we're going to have them pretty much in bed because they're not going to be able to move, right? So then 1, 2, 3, 4, 5, that 6th bullet point there, orthostatic hypotension, that's more from prolonged bed rest, right? And anyways, we are going to see just a lot of difficulty managing, and we want to make sure that we are looking closely again at the respiratory and neurological assessments of a patient that is suspected or diagnosed with a Guillain-Barre. Usually even cranial nerve involvement. In the first suspicion of Guillain-Barre, we're going to be doing this focused assessment, this respiratory and neurological assessment, I would say every 15 minutes, you know, for the first couple days, because it is so quick and we don't want to miss any signs that they're having paralysis of the respiratory system, of that vagal nerve. You know, we need to support them all over, and it could be detrimental or fatal to our patient if we don't recognize these quick signs. So and I say, you know, it's going to be detrimental because respiratory failure can ensue. They will need mechanical ventilation. Respiratory infection will happen because they have poor ventilatory efforts. Urinary tract infections because of the possible genitourinary involvement with the ascending paralysis there. And then look at all of those problems with immobility. So I talked about orthostatic hypotension earlier, but we talk about that virtuous triad. So immobility, endothelial damage, DVT, PE, muscle atrophy, all of these things are going to be rehab potential after we get them out of that 4-week paralysis. Then we're going to start working with the patient with the other things. So we want to supportive care them. So again, we're assessing neurologically, we're assessing respiratory every 15 minutes. We're providing support as needed because it's an autoimmune disease that's causing this demyelinating nerve disorder. Plasmapheresis is an option there to switch out those antibodies, get rid of them so that it stops eating away at our nerves. And we can also give IVIG, which is intravenous immunoglobulin, and that works similar-ish to plasmapheresis, where we're getting good, we're getting rid of the bad antibodies that are attacking our body, and we're getting in the good immune system fighters. And then lastly, again, monitoring for that ascending paralysis. And I think we talked about all this already, but so important. I'll say it one more time. Assess your respiratory function, which includes ABGs, and looking at a good neuro assessment. So looking at all of your cranial nerves, 1 through 12. So checking corneal reflexes, swallowing, talking, moving their tongue, all of those things. Lastly, we're going to touch on a couple other nervous system disorders. We're going to talk about botulinism and tetanus. So first off, with our tetanus, that is an infection of the nervous system, and it can affect the spinal and the cranial nerves. And the little bugger that causes tetanus is Clostridium tetani. And this is kind of like C. diff. It's spores, and these are present in the ground, usually like soil, gardening mediums, and manure and poop. So it can get into our system from, usually it's a dirty wound. So we can get that from like stepping on nails, like gardening injuries, having open fractures, gunshot wounds, and then we think animal bites or human bites are going to possibly open up our integument to the Clostridium tetani spore. So initially we're going to have stiffness in the jaw. So tetanus is also called lockjaw, and then it can go into a fatal form where they might have seizures and like a clonic seizure. So they are, or tonic seizures. So they are constantly in a rigid muscular state, and it's very, very, very painful, as you can imagine. So, and it can lead up to just positioning and tightening of the back and the vertebrae, and I can only imagine how painful this could be, or how painful it would even look to see someone in this situation. So we do vaccinate for tetanus, and it is recommended that we get our vaccinations along with the diphtheria every 10 years as an adult. Then there's botulinism, and this is a very serious type of food poisoning. Botulinism is similar to Guillain-Barre in that it can develop rapidly or over several days, but the difference would be that it is a descending paralysis. And so it starts with kind of difficulty swallowing, seizures, and then it can lead to respiratory compromise and weakness that may lead to respiratory arrest or the need for mechanical ventilation if we catch it in time, or can even lead to cardiac arrest. There is an antitoxin available, but the best way to, not have botulinism is prevention. And so proper canning techniques are big here. So making sure that, if we're buying foods or if we're canning ourselves, that we're doing it the appropriate way and we're closing those the right way. Botulism is also could be found in honey, and so we do not give honey to kiddos under 12 months of age. Thank you.